The following podcast is part of a certified educational activity titled Leveraging Biomarkers to Optimize Treatment Outcomes with ATTs in Early Symptomatic Alzheimer's Disease. New Data and Clinical Pearls from AAIC 2025. Access the entire activity and complete the post-test at peerview.com/EFP860. Downloadable slides are also available.
Welcome to this peer review presentation. I'm Dr. Jared Brosh, Associate Professor of Neurology at Indiana University. Today we're going to be talking about leveraging biomarkers to optimize treatment outcomes with amyloid targeting therapies in early symptomatic Alzheimer's disease. This is based on the new data and some of the clinical pearls that were found in the Alzheimer's Association International Conference in 2025. There are many gaps that exist in early detection and treatment strategies for individuals with or at risk for Alzheimer's disease. Many clinicians tout lifestyle changes as a way to improve cognitive function and reduce the risk for future cognitive decline, but little evidence exists to support that. We know that early diagnosis is critical to help with these lifestyle interventions and to identify individuals who may be treatment candidates with new disease-modifying therapies. It's unclear how biomarkers may be useful in expediting individuals onto amyloid-targeting therapies. And amongst those amyloid-targeting therapies, it's hard to know what long-term data might look like and how long-term treatment with these treatments might help individuals with their cognitive functioning over time. Finally, we need to better understand how we can reduce the risk of ARIA with using these amyloid targeting treatments and how individuals with APOE4 might benefit from these reduction strategies. So our goals for today are to review the latest data that was published on lifestyle interventions and how they may be able to delay or prevent cognitive decline in older individuals at risk for Alzheimer's disease. There are new practice guidelines outlining how we will have best practices for integrating blood-based biomarkers into specialty care settings. We've got really exciting information on open label extensions for both of the FDA-approved amyloid targeting therapies, which we will go over, and also go over the impact of these drugs on APOE4 carriers and new titration methods and techniques. So first, we will highlight the U.S. Pointer trial. This was a multi-domain lifestyle intervention to slow and prevent cognitive decline. It took place in 5 different sites throughout the United States. It included individuals who are over the age of 60, who are at risk for cognitive decline but did not have dementia. These individuals were generally sedentary, and they also had poor dietary intake. They also had to have 2 or more other additional risk factors in order to be included into the study, and in fact, the major reason why individuals were excluded from the study was for being too healthy. In this intervention, there were 2 subgroups. There was no placebo group, which is of interest, but there was a self-guided group, also known as SG in that box to the left. These individuals received 6 facilitated peer group meetings over the course of 2 years, where they were provided education on healthy lifestyle, including diet, exercise, cognitive activity, and monitoring of vascular risk factors. Whereas the structured group involved 38 facilitated peer team meetings over 2 years and also included additional funding for them to purchase healthier foods. It involved involvement in a local gym, such as the YMCA, with structured guidance on cardiovascular fitness activity 3 to 4 times a week, stretching activities, balance, and other resistance activities, as well as getting significant guidance on nutrition. They were also given a subscription to a software package to help them with cognitive stimulation, and were given a lot of health coaching. The characteristics between the two groups were very similar in terms of age, sex, ApoE4 status, race, and a variety of other cardiovascular risk factors. The primary outcomes of this study revealed that the structured group had a statistically significant improvement in cognitive functioning, more so than the self-guided group, but both groups, in fact, improved in overall cognitive benefit. So the score that was used in this study was a global cognitive composite. That was the endpoint. And this involved tests, well-known neuropsychological tests of executive functioning, episodic memory, and processing speed. The interventions were also found to be safe. We're asking sedentary individuals with not necessarily well-controlled vascular risk factors to start exercising and changing their diet. But what was found in the study was that the structured group, which had the most rigorous intervention, was absolutely safe and in many categories had less events than the self-guided group together. There's quite a few conclusions that we can make from this. First of all, we know that this is a very representative and diverse group of individuals that we would see in a community clinic, and that these individuals substantially improved over the course of 2 years when they were given guidance on healthy lifestyle modifications. Certainly, this group of individuals was already at risk, and as I mentioned, many of the healthier individuals were eliminated from the study, but that doesn't mean that healthy individuals would also benefit from interventions like this. The individuals in these studies also had high adherence rates. In other words, once they were in the study and they were in these group meetings and doing this exercise, there was not a lot of dropout. And that is something that I think is very reassuring for primary care and specialty care providers. When we looked at both of these groups over that 2-year period, the structured group definitely had the more significant benefit, and ultimately it appeared as though these individuals were showing cognitive functioning at a age that was approximately 2 years younger than their chronological age. So in counseling individuals about these lifestyle interventions, not only can we tell them that they are improving their cognitive abilities, but that they are very likely improving their risk of developing dementia due to vascular disease or potentially due to neurodegenerative disease down the road. These types of changes will be part of subsequent studies of this US Pointer trial. There are some limitations, of course, without a placebo comparator. It's difficult to make other conclusions. We also don't know much about the amyloid status of the individuals in this population. And these types of things will be future publications from the study, we hope, and we also hope they will continue on with future extension data. When we think about the clinical implications for this, sometimes it's cliche for primary care providers and specialty care providers to suggest things like exercise and diet. But here we have very clear evidence that we can show cognitive improvement over the course of 2 years. Another important point is that anytime that we can find structured community-based programs that help a person with education for diet and structured programs to help with exercise, that those individuals that enter into programs like that are likely to be more successful. So the more resources that we can build in the community and find to be able to provide our patients to will hopefully help them in the long term. Next, I'd like to talk about clinical practice guidelines for blood-based biomarkers. There is a diagnostic work group through the Alzheimer's Association that was developed to try to analyze the current blood-based biomarkers that are available and to develop guidances for all clinicians in using these things. What the panel determined was that there was a large number of desirable impacts for being able to have an accurate blood-based biomarker test. And there was small to moderate undesirable effects. So overall, we want to have desirable blood-based biomarkers because they can help in any number of ways. They're much less invasive than PET scans or CSF. They may allow us to test people earlier in the diagnostic process so that we can identify that Alzheimer's disease pathology at an earlier point. When blood tests are used, that means that there may be a variety of other settings where clinicians are more comfortable in being able to move towards a biomarker diagnosis instead of specialty care settings. But this is something that is the scope of this project is looking at very carefully. We also know that the earlier we make a diagnosis, the more efficacious treatments can be, and the faster we are able to expedite people through this, the less delays they have towards those treatments. In terms of undesirable side effects, certainly with all tests, there can be false negatives, which may lead to additional diagnostics, additional anxiety, and decreased quality of life. We want to make sure that these blood-based biomarkers are used by trained personnel and they're used in the right populations. Those types of things can reduce the number of undesirable effects. We want to make sure that individuals who are tested have a high pretest probability of having Alzheimer's disease, not a low pretest probability. We want to make sure that once a diagnosis is made, that we are able to help expedite that person to appropriate follow-up and not have things stall. So when we looked at these recommendations overall, what was decided was that a blood-based biomarker with a greater than 90% sensitivity and a greater than 75% specificity would be a useful triaging test. This test would therefore rule out Alzheimer's disease pathology with a high probability. But then a positive result would need to be confirmed with another test, such as an amyloid PET scan or cerebrospinal fluid. If a blood-based biomarker had both 90% sensitivity and specificity, then this would be able to serve as a confirmatory test, not necessarily needing a confirmatory amyloid PET or spinal fluid. So the good practice statement here, as a result of these conclusions, is that we definitely don't want to use blood-based biomarkers for someone who comes in with cognitive complaints. We want to make sure that that person has had a comprehensive clinical evaluation. We have measured to see if they have true cognitive impairment and that other causes for cognitive impairment have been ruled out such that the pre-test probability of Alzheimer's disease is high when we are using any type of a screening test, including blood-based biomarkers. The panel understands and recognizes that there are quite a few tests that are available clinically speaking at the moment, but they felt that ranking or endorsing specific tests was premature. There is low certainty around the test accuracy, and this is where the guidances from what the panel described are difficult to immediately apply to the clinical setting because the evidence around the use of these biomarkers in diverse populations is still building, and it's unclear if the sensitivity and specificity that are listed for some of these tests apply to a broader range of uses. There's also been a lot of variability in the test development, validation, implementation, and the rollout on a mass scale basis. So in a blood-based biomarker may also have clinical scenarios where testing is not appropriate. As an example, a blood-based biomarker test may not be appropriate when we decide that there would be low utility in knowing if Alzheimer's disease pathology is present, if the test is unlikely to change how we manage a patient, then the test really isn't necessary. If we know that this person has other modifiable or temporary conditions, this would not be a good setting for blood-based biomarker testing. If there's limited life expectancy, if the person is very far advanced in their disease. We also know that there are other factors that can affect the accuracy of these tests, and that includes other brain pathology, other acute conditions like a brain injury, stroke. We know that severe chronic kidney disease and other neurodegenerative conditions, such as Lou Gehrig's disease, may impact the accuracy of these blood-based biomarkers. And there are also other drugs, prescription medications that can interfere with the accuracy of these blood-based biomarkers. Some of them are listed here, but there are others that we haven't completely explored at this point. So the summary and conclusions from the panel, this blood-based biomarker clinical practice guideline conclusions, are that this first iteration, it only really reviewed the evidence of blood-based biomarker testing in individuals with cognitive impairment in a specialty care setting. Again, we know that blood-based biomarkers are used in primary care settings, general practice, and throughout society, but these tests have not been validated, and the accuracy of the tests in those populations is unclear. Therefore, it's difficult to say at this point if these tests are able to be a comprehensive test, eliminating the need for spinal fluid or PET at this moment. We know that these tests, one of the blood-based biomarkers has received full FDA approval. And this has definitely impacted our availability of these tests, integration of these tests into electronic medical record systems, and the availability for us to do EMR-based ordering of these assessments and the use of these assessments in hospital-based and clinic-based laboratories. So with that FDA approval, we are seeing a major increase in the amount of these tests available, and we're seeing many, many more of them in specialty care clinics. How do we integrate these into the workflow is a great question. Workflows are being developed in the primary care setting for when the most appropriate timing of those tests may be able to be done. Again, data is growing on the sensitivity and specificity of these tests in those types of settings. And in the specialty care setting, in ambiguous types of situations, the blood-based biomarkers might help expedite appropriate workups for individuals who have cognitive impairment. Many specialty care physicians have seen blood-based biomarkers come with referrals for their patients. And this is, I think we are still at the point where confirmatory tests are necessary given the ambiguity in the accuracy of these tests in all settings at this moment. Next, we will discuss the lecanemab Clarity AD open label extension in early Alzheimer's disease. A 4-year follow-up open label extension for lecanemab has been completed and published. Many of you are familiar with Clarity AD, where 10 milligram per kilogram biweekly IV infusion was used for 18 months versus placebo. The open label extension included individuals who were on 10 milligrams per kilograms biweekly, the same dose as the blinded portion of that study, a 10 milligram per kilogram monthly dose, or a subcutaneous formulation that was felt to be equivalent to the intravenous dose. A variety of cognitive and biomarker-based measures were a part of this open label extension. In this graph, we can see at the 18-month mark a difference between lecanemab and the placebo comparator arm in the Clarity AD study. Also added in this graph is the ADNI-4 comparator, as well as a European-based comparator called BioFinder. And following along with those two comparator groups, since the placebo arm of the Clarity AD study has completed, we're able to see a continued progressive benefit for the use of lecanemab over a 48-month period. We can see that by the endpoint of 48 months, that there was a change in the sum of boxes score between 1.75 and 2.17, depending on the comparator group that we use. And at the 18-month mark, this was about a half a point on the CDR sum of boxes. So we can see that there is a continued accrual of benefit over those 48 months with an expansion and a increasing difference between the treatment and the placebo arms, or at least in this case, the comparator arms. We can see that these treatments, based on the ADNI cohort, reduced the risk of progression to the next stage of the disease, and particularly reduced the risk of progression to dementia. Another subgroup was analyzed, and this is a group in a tau PET sub-study from the Clarity AD trial, where individuals with low tau were identified in both the placebo group and in the treatment groups. And what was noticed was that in the low tau population, there was a 69% of individuals showed no decline in the CDR sum of boxes over 48 months. Additionally, there was a subgroup that showed a clinical improvement in the CDR sum of boxes over that same period of time in this low tau population. There was no significant change, no significant signal noticed in the safety data over this open label extension period. There was a continuation of expected ARIA, but nothing out of the ordinary in terms of open label extension safety data. So the summary and conclusions from this is that we can observe a consistent disease modifying impact of the drug over time, with a growing difference between the treatment arm and the comparator arms. We also saw that in a low tau population, there were a subgroup of individuals who improved clinically in the CDR sum of boxes, and a large majority of individuals who showed no clinical decline over 48 months. This type of information is incredibly valuable to primary care and specialty care physicians in being able to have conversations with patients about what the long-term benefits of these treatments are like, and also to be able to talk about long-term safety implications. Donanemab in early symptomatic Alzheimer's disease also published an open label long-term extension of these medications. The original TRAILBLAZER-2 study completed after 76 weeks, and there were two groups that were followed in a long-term extension period. There was the early start group, which was individuals who were started on lecanemab and then continued on treatment until they had plaque clearance. At the beginning of this long-term extension period, 31% of individuals were still being treated in the early start group. The delayed start group were on placebo in the randomized controlled period, and therefore were all started on donanemab and continued until those individuals reached plaque clearance. We know that there are three potential outcomes which also apply to other types of amyloid targeting therapies, and this is that if beyond the 18-month period we see a continued widening of the benefit between the treated group and the comparator group, that we are seeing a increased benefit from the drug treatment, which would be the green line A. If the lines become parallel, then that means there is a maintenance of benefit. And if they converge, then that means there is a waning of treatment effect. In the early start cohort shown here, monitored over an additional 18-month period for a total of 3 years, there seems to be a continued treatment benefit. Once again, there are 31% of individuals still receiving treatment at the beginning, but at various points throughout this 18-month follow-up, they would come off of treatment based on amyloid clearance. And a great number of individuals were off of treatment at the time of this 36-month follow-up. Compared to the ADNI cohort, there was a growth from a 0.6 CDR sum of boxes score to approximately 1.2 in this cohort of individuals, which is approximately 400 individuals. In the delayed start cohort, There was also a benefit that was noted, where at the end of an 18-month treatment period, compared to an ADNI comparator, there was a 0.8 difference in the CDR sum of boxes. So this is very interesting. And in fact, when we look at that group of individuals who started at this 18-month mark, we see that a great majority of them were either mild, rated as, in this MMSE category, rated as mild or moderately impaired based on an MMSE score. The late start individuals also showed a rapid reduction in amyloid based on centiloid changes, and this appeared to match up with the early start group. And that when we look at that early start group on the right graph, we can see that once clearance was achieved, even over the long-term extension period, they did not cross the threshold in general for a positive amyloid PET, and we saw a reaccumulation of approximately 2.4 centiloids per year. There was a similar safety profile between the early start and the late start group, so there was not a significant difference in the development of treatment effects, even when treatment was delayed into a further range of cognitive impairment. In summary, donanemab benefit continued to grow over 36 months compared to an ADNI comparator, and this is when many of those individuals had stopped treatment and had shown amyloid clearance. We also know that amyloid reaccumulated very slowly over the course of the long-term extension period, with very few individuals becoming amyloid positive after they had stopped. There were no new safety signals that were seen in the long-term extension period. This data may reinforce the treatment with donanemab and how early stopping criteria with amyloid clearance may show continued benefit. When we think about the long-term extension data from both the Clarity AD open label extension and the Trailblazer 2 long-term extension, what we see is a clear message that both of these medicines and amyloid targeting therapies that are available on the market have a continued clinical benefit over time. There is a continued separation between comparator study groups and those individuals who are being treated in terms of a global cognitive and functional score. Both of these studies reinforced the benefit of early diagnosis, and we know from this data and previous data that earlier intervention with amyloid targeting therapies make a difference in our ability to maintain our cognitive abilities over time. There is a higher percentage of individuals who showed more cognitive impairment in the Trailblazer-ALZ 2 study compared to Clarity AD, and this may impact our ability to compare those two studies head to head. But overall, the long-term data shows continued benefit for individuals on either therapy. There is some difficulty in understanding whether or not maintenance therapy is key to this continued benefit or not. And the Trailblazer 2 long-term extension seems to imply that continued dosing may not be necessary to see this long-term benefit. I think that over time, we are going to see continued long-term information, the introduction of potentially more biomarker data that will be published from both studies that will help us eventually understand the mechanism of how these drugs work and the need for continued therapy over time in the future. A final discussion that occurred during the Alzheimer's Association International Conference was the 18-month results from the Trailblazer 6 study, which is a study of the modified titration of donanemab and how it impacts the risk of side effects. As a reminder, this modified titration involves the movement of one vial of donanemab from the first infusion to the third infusion so that there is a more graded increase in the dosage of the medication through the first three infusions. What was seen in the 76-week data is continued reduction in the amyloid PET signal using centiloid values. And when compared to the standard dosing titration, we see more or less the same change in reduction in amyloid PET. We also see a significant reduction in ARIA-based side effects using the modified titration. Once again, these are smaller groups than what was studied in the TRAILBLAZER-2 study, but we have about 212 individuals in the modified titration and 207 in a standard titration. And when we look at the ARIA-E data, we see a significant reduction in all comers there, going from a 24.2% risk of ARIA-E to a 15.6% risk of ARIA-E over the 76-week monitoring. There's also a significant risk in one of the more concerning aspects of ARIA-H, which is superficial siderosis. This significant reduction in superficial siderosis was seen across all comers as well. This slide is meant to show primarily that when we look on that right graph, the APOE4 homozygotes also showed a significant decrease when using the modified titration, making it safer for those individuals to be on donanemab treatment. On the left-hand chart, we see that the severity of the ARIA that is present was much less in the modified titration compared to standard titration through the 76-week mark. In summary, the modified titration over 76 weeks showed significant ability to lower amyloid levels as measured with centiloid values on an amyloid PET, and it also showed a significant reduction in ARIA-E. Because of this, the FDA has approved this modified titration, and it is currently approved in a variety of other countries and by the European Medicines Agency. I think that there is a significant clinical impact and applicability of this Trailblazer 6 data, adding to the Trailblazer 2 information that was previously available. A clinician may now feel more comfortable with the safety profile demonstrated in the Trailblazer 6 studies. One might also consider inclusion of APOE4 carriers and even homozygotes in treatment. And I think that this type of discussion about this new set of data with patients will help them feel more familiar and comfortable with dosing with donanemab. The key take-home messages from the Alzheimer's Association International Conference are that the U.S. Pointer study showed that lifestyle interventions can significantly improve and protect cognitive functioning in older adults who are at risk for cognitive decline. This has a lot of clinical applicability in both primary care and specialty care clinics and adds credence to the lifestyle interventions that we talk about with our patients and how they can see not only decreased risk of future cognitive decline, but an actual increase in their cognitive abilities. Blood-based biomarker guidelines are rapidly evolving. It's clear that these blood-based biomarkers will have a positive benefit for both specialty care providers and primary care providers in the future. However, we need to understand the accuracy of these blood-based biomarkers in more generalized use settings. And hopefully this information and these guidances will be available over time. Open label extension data from the Clarity AD study showed a continued benefit of treatment over a 48-month period compared to an ADNI comparator. This type of information will be helpful in guiding patients on that medication and what the long-term benefits might be. Similarly, the long-term extension data of the Trailblazer-ALZ 2 study through 36 months also shows continued benefit for those individuals on donanemab therapy and may support limited duration treat-to-target dosing. Finally, the Trailblazer-ALZ 6 76-week data reinforces the modified titration of donanemab, which significantly lowers ARIA-E risk while showing maintained efficacy in reduction in amyloid PET scores. This is now the FDA-approved way to use this medication and also shows benefit regardless of ApoE4 status. We hope this summary of the Alzheimer's Association International Conference was helpful to your understanding of the latest data that's been published, and we will look for your continued viewing in the future.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/EFP860.